a minor in health education. She continued her graduate studies here at Concordia University, receiving a master's degree in nursing education. She completed her PhD studies in leadership, learning, and service in higher education at Cardinal Stritch University, Milwaukee, December 2012. Dr. Crary began her nursing career in the emergency room and ICU, and over the years has practiced in several areas, including school nursing, home care, hospice, and medical case management. Professor Crary has been involved with education of nurses from LPNs to the graduate student in the skills lab, classroom, clinical, and simulation learning labs. Her area of research is focused upon students' perception of learning clinical competencies in the high-fidelity simulation learning environment and the role played by their perception of the level of reality in that lab. She will be continuing her research with former colleagues in the Wisconsin Technical Colleges on formative learning environments and simulation learning experiences. Dr. Crary currently holds 3 patents for teaching tools she developed for use in the simulation learning environment. Dr. Wendy Crary is currently the chairperson of the non-traditional nursing program at Concordia University. Professor Crary is one of the original founding members of the Sigma Theta Tau chapter at Concordia, is a member of Sigma Theta Tau International, is a board member for Wisconsin Nurses Association and Wisconsin Center for Nursing, Wisconsin League for Nursing, National League for Nursing, the Society for Simulation in Healthcare, and now WELSNA, serving as the council coordinator-elect. Mrs. Crary and her husband have a large family with 6 adult children, 4 of whom are now married and 8 grandchildren. After recently moving to Fox Lake, she and her husband are now members of St. John's and are blessed to have a strong Christian faith that has sustained them through life's ups and downs. And with 6 children, those ups and downs happened on nearly a daily basis. Today she will discuss a study of the pre-licensure nursing students' perception of the learning environment as helpful in achieving clinical competencies and their perception of the impact of the level of fidelity. We are very lucky to have someone with so many credentials and skills, so please help me in welcoming Wendy.
Good afternoon, everyone. Thank you for coming and choosing to spend some time with me, and I'll try and keep you a bit entertained and engaged with our postprandial slump, right? So as it said, I did my PhD research in the simulation learning environment. This is an environment that I was privileged to be working with at Moraine Park Technical College when I was teaching there, when it really came on the scene for nursing education. And I was there when we bought the first mannequins and set everything up and added it to the curriculum and figured out how were we going to thread this through the curriculum and make it meaningful for our students so that it wasn't just a game and it wasn't just seen as a day off from clinical out at the acute care setting or out in the community. Because we knew this was going to be important. We knew this was going to be a tool that was going to be valuable for us as educators. We just didn't understand how to use it. And when I decided to do what I was going to do for my dissertation research, I knew I needed to investigate this a little bit more. What has been done over and over again until just very recently was looking at the students, how did they feel when they went into this simulation learning environment? Did they feel it was worthwhile in there? Did they enjoy it? It was all looking at qualitative aspects of what was going on in there, and no one had been measuring quantitatively whether this actually impacted them in their learning. Could we measure specifically, very precisely, outcomes of their learning? And so what I thought was that we needed to start with trying to understand whether how real it was, how much time we were investing in this, making it real. Was this important to them? Because setting up the simulation learning lab is very expensive. How many of you actually have had experience in a high fidelity simulation learning lab? Okay, and so you know that this can be quite an expensive endeavor beyond just buying the latest and greatest mannequin. And so I thought I needed to start by finding out from the students' perception, how important was this? And then what I did was, is I needed something to measure that against. And so I looked at the clinical competencies developed by CUSIN. Anyone familiar with CUSIN? Okay, yeah, so Quality and Safety Education of Nursing. And this is something that was started back in 2008, started and they really developed it 2010, looking at what do we need to prepare our nursing students and eventually our nurses in the area of quality and safety. And then they built competencies, and we'll get into those a little bit. So this is what a simulation learning lab looks like. I found this picture, and to set up in your mind what this situation looks like. You've got two people on one side of the glass, they're working on a mannequin in what looks like a care environment. And then you have the faculty with the computer and everything on this side. And it can be very cold of an environment. And it's that to a sense looks like reality, but in another sense, it's very far removed from reality. So it's our job to make it look more like reality. And that's what the significance of this study is that if we're going to invest time and money and at several different levels, how important do the students feel that that level of reality is in there in order for them to be able to learn? And we want them as the benchmark or the measuring stick against what we want to look at how they're learning and what they're learning is the CUSIN competencies. So some definitions. Simulation, pretty simple. We're trying to mimic a real life environment. The fidelity is the extent to how well we've done that. How do things look in there? Does it look like what they're used to seeing when they're out at the patient bedside? Clinical competency. I really wanted this to be applied at the care at the patient bedside, so having the necessary knowledge or technical skill to perform a given procedure within the bounds of success and failure rates deemed compatible with acceptable levels of care. So that's really what we were looking at, is how are we measuring whether they are doing an acceptable level of care. Helpful, I just wanted to know whether it was useful for them. That was what I was measuring, is how helpful they found it, and then how real. So the theoretical framework I used for this was Kolb's theory of experiential learning. I felt this matched the best to what students are doing. It's how they're experiencing reality in there and what they're really expected to do, their role performance of becoming a nurse. And then Arthur Combs, he talked about how important perception is. So if we put a student in an environment where we want them to learn and they don't perceive it as being important or of having any worth, how much are they going to actually engage in the learning? It's not going to happen, or it's going to happen at a very low level, and we've expended a lot of time and energy in there in something that maybe wasn't even going to be worthwhile to them. So some other ones, theorists that I used for the study. The one thing I would like you to get out of this is these two key points right here. That learning is dynamic. It's an exchange between the student and the environment, and it's back and forth and back and forth. And that it's very important for us to set up visual cues for the students in order for them to learn. Some others support the value of educational approaches that link the concepts and techniques from the academic environment to what they're going to see out at the patient bedside is no longer questioned. We have to absolutely do that. I was mentioning some resources being new to the simulation learning environment, this is an absolutely wonderful study that was done, and I would highly recommend it if you were interested in this environment and teaching in it or understanding it. That would be a place to start. All of us should remember and know who Patricia Benner is. And so what she spoke to specifically about the simulation learning environment is that we should be looking for things that help students confirm what they already know and to build upon that. Remember her novice to expert idea? And so that's how she's finding that the simulation learning environment is important for them. Wallner and Olson said that it's the contextual meaning, putting them into what is as close to reality environment so that they can build a context around it and find a way that they can take this new learning and actually apply it out in the setting. These are speaking to the importance of preparing the environment and a simulation learning environment and doing it very purposefully. We can't just hope that the learning happens in there. We have to actually guide their learning from even before that they step into the learning environment. We have to prepare it and do it very carefully. So this started with the Institute of Medicine's report in 2001, bridging the gap in your learning, and it's crossing the quality of learning and patient care settings. Quality was very, very important. And then the Institute of Medicine came out in 2010 with a report for a radical transformation in how we do nursing education. And that's one of the things that I built this on. So what I wanted to know is if the students actually perceive the high fidelity simulation learning environment as being an area where they could develop their ability and clinical competency in there. I also wanted to know how important the level of reality was in there for them to be able to learn. I also looked at I did their demographics and some of the male, female, how many years of experience they had out in the clinical setting and how far along they were in their program. And so some of those things were also what I studied in there. So let's see here. So the methodology, it was non-experimental. I let the colleges run their scenarios, whatever. I didn't manipulate the scenarios that they ran in the simulation lab. I just tested the students, gave them a survey. It was an online survey that they took after they had been through the simulations. And so there was both a quantitative and then I followed it up with a qualitative phase where I held focus groups and I built on what I found as the results on the survey, and I'll show you those. Kathy, did you take the survey when you were at Concordia? No? Okay. Alrighty. So there was 24 items on there. I used Qualtrics, which is an online survey. It's kind of like SurveyMonkey. I'm sure everyone's taken one of those. I developed the questionnaire. I got permission from QSIN, the Quality and Safe Education of Nurses, to use their QSIN competencies and the associated actions that go along with each one of those, and I built my survey off of that. It was a Likert type scale. You've all taken those. So these are this is how the survey was built, but over there the QSIN competencies are, to give you an idea of what they are. They felt that we need to personalize patient care. That's nothing new, we know that. Thinking about our speakers this morning, wasn't that what you got out of it? Was that it needs to be personalized, that just has to be. Evidence-based practice, if there's someone in this room who hasn't heard the mantra out there of evidence-based practice, I don't know where you are hiding, but that's exactly what we have to do. The importance of teamwork and collaboration. I don't know about the other educators here, and if there's any nursing students or new nurses, what we tell them is that you're not a team of one when you go out there. You don't have to be the person that makes all of these decisions about developing the plan of care or implementing it. You are one of a team. And so that is one of the things that we needed to make sure that we were teaching them while they were in school, is understanding what the other members of the team do, who they are, and how you should be interacting with them. And one of the things that I always want to make sure and give to the students is the understanding that they are a valued member of that team. Even as a student or even as a graduate nurse, they bring value to that team. So speak up, see yourself in that role, that feeling of self-efficacy. And that's one of the things that giving them these practice scenarios in the simulation lab and basing them on interprofessional education models and teamwork is that we're building that skill right into them. But can the students learn those in the simulation lab? And so that's what we were trying to find out. Always talking about quality improvement. And these are some of the sample questions that I put in there. Obviously, safety is a big one, and there's so many elements of safety that we can build into the simulation learning lab that if they learn the right and the wrong here before they get out to the patient bedside, that's just an all-around better scenario for everyone. And then the use of informatics. Now, when I did this study in 2010, 2011 is when I gathered the data. Informatics was the up and coming thing, and when there's different concept of what informatics is, and it's not just how do you use Epic or Cerner. That's not the only thing. So there's other ways to support your decision making out there. So the survey, I developed it myself. I had it. I addressed validity and reliability with having peers taking a look at the survey. I did a pilot study and focus groups. I had 167 subjects in the group. It was just a census sample. I worked with 2 baccalaureate programs in the Milwaukee area, and it was all the students that were in clinical and doing simulation in this particular time frame. And I'll talk about later about where I'd like to go from there. The focus groups then were held on the campus. I held a couple of different ones. There was at Marquette and at Concordia University. They were only about an hour long, and that was the best part. I was only going to do a quantitative survey, and then the chair of my committee said, well, no, you need to now do a qualitative focus group part. And I'm like, oh man, so that sent me a whole semester back. But I am so glad I did that, because that was the real meat. I really started to understand from the student responses. So it was the fun part. So these were some of the these were the questions that I had them think about as we were going through the focus group. And so what I got out of the responses were the number one things I got out of this was the students' perceptions and their recommendations of how we could do it better in the simulation lab. So that was very, very important. So I ended up with 11 competencies and then professional role development and items, sections of the survey. I broke it into that, and for 8 of the 11 competencies in the professional role responsibilities, they found that the high fidelity simulation learning environment was helpful. So that was fabulous. So this is just an idea of all of the things that I went through, and then where were our high scores and where were the lower ones. We'll get into that. There was my histogram of my results. So then I wanted to know what the correlation between the students' rating of the level of reality and then how helpful they found it was. And I came up with 0.659. So that's a significant amount. I would like it to be stronger, but at least it fell into the significant range. And what was important was the p-value, which means that the likelihood of there being other influences beyond being part of this study on their answers was non-existent. So then I looked at the second research question I wanted was the correlation, finding there's the relationship between the level of their rating of reality and then did that positively impact their ability to learn in there. And I came up with a 0.617, and again, a p-value of 0.000. So again, that's in the significant range. So they needed it to be real, or they didn't feel like they were going to learn. This is looking at the some of those demographic things, and the only thing that actually loaded on here was the years of experience out in working. So the more experience they had with reality, the more important it was that it was real for them to learn. That's not a big surprise, right? But we needed to measure it, and we needed to have it written down. So those are some of the other demographics. But so now this is the fun part. I don't know. I like doing research, so to me this is fun. So what they said was that a barrier for them to learn was fakeness. The fakeness of the responses from the mannequin, the verbal responses, or we were just talking about IV arms and not being able to, if we can teach them how to start an IV, we can teach them the mechanics of it, but how can we teach them the patient-nurse interaction part, the emotional intelligence things that we need to teach them in there. So we needed to work on this basically. And now, they felt that this team was really, really important. They found that providing patient care in a simulation learning environment was stressful. And the reason being is that they felt it was not a formative learning environment where we were working with them, we were facilitating we being the educators were facilitating their learning, that we were standing there being their coach, that they felt that they were being judged or tested, or as we call summative learning. And so and I know specifically for the Concordia students, I can say for sure that as many times as the professors in there, the instructors were telling them, we're not grading you on this, we're not grading you, they still felt like they were being that way. So somehow we have to do it more often, is what they wanted. They wanted to have it every semester or more than every semester, and they wanted to have access to their instructors or their professors during the time that they were in the lab. But they felt also, though, this was interesting, that even though that they felt more stress and there was more anxiety, they thought it was a manageable level of anxiety, and it actually made them perk up and want to really focus, and they felt like they were learning more. So they needed a little bit of stress to make it important, and they would, be focused and engaged. They liked the idea, this is teamwork and collaboration scored very highly for the students. They felt that this was a good environment for them to learn how to work as a team. Because typically what we do in the simulation lab is we take a group of 2, 3, or 4 students and we put them in the room with the mannequin and have them work their way through this scenario. So they're just there and with more than themselves. So it was a good way to learn how to negotiate and to communicate. So communication was another highly rated item on there. And professional socialization, That scored highly, but what I got out of the focus groups was that they thought it could be done better. That if they had more interprofessional education and they wanted it to be with students of other schools within the healthcare profession. So bring in the OT, the PT, the pharmacy students. Have someone play the doctor, that's fine, on the phone. Bring your lab techs in. They just were hungry for that interprofessional education in this. They said this was the ideal situation where that could happen. We can't create that out on the floor because the impact of the decision making is too real. So they thought that the importance of the level of reality was supported in the students' discussion on the patient-centered care items, the psychomotor skills, the safety, the evidence-based practice, and informatics. They really like the idea of having an electronic health record. So those of you who teach in simulation, do you have some kind of an electronic health record? No. Okay. Students are saying we need that because what do they see when they go out to the clinical setting? They've got to do it. So I know it's expensive. We tried at Concordia to create our own, working with our IT department, at least to get a medication, a MAR, administration record, in a way for them to look up the meds and check off the meds when they gave them, and a very rudimentary way of putting in orders for them to pull up, but there's much more sophisticated systems out there.
The hospitals that you do clinicals at, if they have an electronic health record, they may have, there's a term for, but they're fake accounts
Right.
that you could probably tie into.
Like a play environment, we used to call it.
We call them Donald Duck and Bugs Bunny, and they all have.
Right.
So there's no mistake of that they're not real patients.
I know Epic in Madison was more likely to share, but there's a lot of upkeep that has to go on. They can't just you can't go into the live environment, but I mean they would provide a play environment, but it's the upkeep that became a barrier. And so that for Epic to come in and update every time there was something new, and maintain it, because things just go wrong, right? Technology isn't perfect.
And we found with our Epic playground that it's nowhere even closely resembling to the actual Epic environment that we actually chart on. So the playground's not accurate at all.
And that we ran into very, very quickly. And so there, but now, and I'm not going to speak, I'm not here to promote any companies, but there are companies out there, but they have like a $10,000 price tag on them. But what the students are telling us is it's really important for them to be able to transfer from this environment to the real life and be able to make those decisions that way. Okay, and then so they do find it to be helpful. I was thrilled with that, and the reasons that they didn't find it to be quite as helpful, the good news was that we can actually easily monitor those because now we know what they are. I mean, this was not a huge study. But it's a beginning study. It was a dissertation study. So that, and I'll talk about what I'm going to do next. So the important thing here to get out of it is we need to make it as reality as possible. It's really important for the students. They don't get confused because it's not what they're used to seeing out at the acute care setting, but they can create. One of the theorists that I used is students make memory tapes, recordings, and I'm dating myself, tapes, not no VHS stuff, but they create those in their mind. And if we can do that here in the simulation lab where it's safe and we're not actually practicing on real patients, that is incredibly valuable, and the students build up that level of confidence, and they say that they can carry that to the bedside, but they can't if they don't have a correct memory tape, basically. Okay. So the importance of what the findings were for our academic world and also the practice world is that we can use this to develop competency. We also can use this to test competency. We need to put the money behind it, and we need to do the ongoing training, the professional development for the educators that we're placing into these expensive environments, and keep them up to date, because things are changing. I don't know how else to say that and put the emphasis behind it. So I felt that this was a catalyst. This was the beginning study. This is it just gives more of an emphasis behind that we need to study this more directly, fully, and very purposefully is what we have to do with using these environments for teaching or for competency training after they've already gotten their license. So this is what I had said, is that we really need to do, we shouldn't be throwing faculty into these environments and expecting them to know how to teach. They absolutely have to be given some direction. It's not the same as teaching in the skills lab. It's not the same as teaching at the bedside. We need to help them understand how to use this tool, because that's basically what it is. It's an educational tool. So the more strongly that we can develop the competencies that the students felt were more challenging for them to do, and unfortunately the number one, or the lowest one I should say, was evidence-based practice, and that's a little scary. And safety was right down there at the bottom as well. So we need to spend more time in developing those areas. And the students said that the evidence-based practice, the reason was that they didn't have the normal information tools that they find when they're at the real live patient care environment. When you think about it, look at all the tools that are built into EPIC, as far as, you know, looking up they have an online drug book, the drug formulary. They've got the patient education materials. They can look up everything on the intranet. And I don't know about other people, but putting the most current edition of the drug book in the corner or on the counter, that's not enough. You know, we have to do it better than that. And this is what I love. I love these last couple of sentences here. We need to use this pedagogical tool, it's a tool, and to do it for formative learning. And really be in there and coach the students, because we're the practice experts as the educators. Whether you're out in the practice setting or in the academia, we're more faculty involvement. However, there is one study that I came across that said that if you have the students start in the environment and you're not present as the educator, and you come in and interrupt the flow, their learning stops, their reliance on their own learning stops, and they move their focus onto you and their dependence on you. So it needs to be that you are actively in part of it, and how can that be done? Pre-conference. So if you set them up with all of the knowledge and tips and tricks, and you give them the pre-learning before they come on the disease or the injury or whatever they're going to be going through, that's where you're doing the coaching. And you don't try and trick them. When they're in the environment, the scenario is going, the whole idea is not to trick them or throw something at them. Let them work their way through, and if they make poor decisions, well then, you know, the patient starts to go south, and they're on that critical pathway. But give them a chance to recover. Give them the tools. Don't leave things out purposefully. Don't put barriers in their way. This is, I don't know if any of you are familiar with Robert Greenleaf, but he's very much into service. I was thinking of our speaker last night, if you were here, and he was talking about servant leadership, servant learning, being servants to our students, and I love this quote. So that this is what drives me, is this kind of sentiment. So what are the implications for research? As I said, I think this is just a very basic foundation upon which we need to build. Where I think we need to go with this is to make it a quasi or truly experimental, and we need to manipulate the level of reality in the simulation scenarios for the students and see if they come up with the same results or even stronger. So that's where my inventions come in, and what I've invented is a thermometer, a programmable thermometer. It looks just like your IVAC thermometer. The only thing is that you can program in the temperatures that you want the students to find as part of the scenario that they're going through. Right now, we put sticky notes out and we cover up the thermometer and we have them lifted up, and that's the temperature they're supposed to find. Or there's a voice that comes from the ceiling and says the temperature is this with this. I mean, is that reality based? That isn't. And my second invention should be out on the market by this fall, and that is the programmable blood glucometer that we can put in. It acts and works just like a regular glucometer, and we can put in the glucose levels that we want for the students to find, and then a programmable pulse oximeter, which is a standalone that's not tied to the mannequin. Right now it's tied to a screen, and that's not going to work with the new 3G models that you could come and put on the table here and teach from the classroom. So what I want to do is add those three things into some of the scenarios, just randomly assigned, and see if we get the same results from the two groups, the ones who just don't have anything, and then these three items in there. So that's my plan. The next piece of that would be, I did it only with baccalaureate degrees. I was pre-licensure and baccalaureate programs. I was going to do it with associate degree programs, but that got a little bit too big for dissertation level research, but that's where I would like to go, and definitely I want to manipulate the level of the environment and see what we get there. So, any questions? Yeah.
I know it's probably not a research, though it could be.
Mm-hmm.
Have you done any with the clinical faculty that take the students to the schools themselves? Because that's, in my limited teaching, I have found that most of the instructors who are at the hospital, doing the clinicals, are really not in touch with what's going on in the clinical lab.
At the two schools where I did collected the data, it was not the same people that taught at the patient bedside out in real life and taught in the simulation lab. And with our technical colleges, they have typically assigned faculty that teach in the simulation lab. So I don't know how we can do that. My experience when I taught at the technical college, I taught the clinical out in the field that I did the simulation for, and that really, I think.
Well, I'm just wondering if the clinical, the folks at the hospital, maybe need to come in and play student for the day. So they know what the students are going through.
Well, I know with our master's nurse educator program at Concordia, I have the nurse educator students come in and they spend a half a day learning how to teach in the environment. We put them through a scenario and they have to learn how to use the mannequin, then we bring them behind the scenes and show them how to use the tool. I mean, it's nowhere near the orientation that you get from whoever you buy your mannequins from, if it's Laerdal or Medi or, yeah.
At Madison College, each clinical instructor is required to have a simulation as part of their clinical, so they all are having to do it. They fought it at first, but everybody is doing it.
Why do you think they embraced it and they came on board? Maybe that'll answer.
Well, it's a completely different skill set. You know, nurses, we hate IT.
It took them a while. They were just thrown into it, like you said, you can't do
You
that.
can't do that. That's not fair.
And as they got trained, they came to be believers that it was useful.
And how did they get trained? See, that's the,
Well, we have one coordinator in Madison, so he is very involved and loves it, and it shows. So he'd take them all under his wing and gradually, sometimes one at a time, would just get them used to doing it. And as people became happier with it, and then they'd have speakers come in and they'd send them to training,
okay.
so.
And how many have gone to formal training with the Laerdal or Medi? Yeah, it's intense, right? I mean, it's very structured. They know exactly what they're doing. They give you.
Hasn't always been that way.
No.
I was part of the original group that didn't know what we were doing.
They've gotten much better. You get a certain number of training sessions and people get to go and attend it every time you buy a mannequin or the software, but you need to have some of the articles that I read in my literature review was that you need to have a champion at your university who it has been formally trained, gets the updated professional development, and knows how to educate. And has a passion for it. Otherwise, it's yeah. So that was important. In conversation, we were talking last night about how can you use this if you are already out there and practicing. How can hospitals or I'll say healthcare providers use the simulation learning environment as a way to check annual competencies, rather than just going through a self-evaluation and, I think I'm great and, I'm good, I don't need anything. How can we actually test them, and the competencies are a good standard or yardstick or measuring tool against what to use it. So, any other questions?
Talking about for annual competencies, my supervisor has us going through some of that right now to make sure we know how to give an IM injection, whether it's deltoid, the ventrogluteal and all that kind of stuff, and how to do, what else did they want us to do? EKG. And so we have one of the RNs in the clinic coming and watching us while we do this to a patient.
No.
But it's not, they're in there for 5 seconds to watch you, and then you're done, and that's about it.
And I guess if I'm the patient,
Yeah.
is
The
that what
patient
I
is asked,
really-
of course, do you mind if they watch me do this? And they're wondering, okay, why do you have to be
why do you-
watched?
Right,
I don't
so-
like this.
So let's bring you
Yeah.
in and use an IV arm or an injection pad, but you know what, that's kind of like looking at it from, this way. We need to look at it big picture, because that's coming from the old medical model where the nurses are the handmaidens to the doctors, and what we do is we do the skills. That isn't testing whether we can put together an idea of what's going on
Critical
with this
thinking.
patient, with the critical thinking, the clinical reasoning, looking at the symptoms and what we're being presented with, and can we recognize emergent issues, and do we know what to do? Do we know when to call the doctor? Do we know whether to implement the orders we were given based on what we've seen in the patient? Are we just going to blindly implement the doctor's orders? Are we going to use some thinking and say, wait a minute,
Or even if you're in a clinic, recognizing who needs to get an EKG now, and who needs to get an EKG once the doctor says get an EKG.
Right, because I'm in a clinic.
Right.
So I'm not at the bedside as far as nursing goes, but yeah, because then it would be nice sometimes if they could tell us, okay, you're seeing a very strange pulse. Why can't you just go and do an EKG? and have that and give it to the provider instead of having to wait for them to say, let's get an EKG on this guy.
And that's probably because of what?
Payment.
Reimbursement.
Right.
Mhm. Yeah.
And I was just gonna say with electronic charting and Epic and whatnot, we can't do things like that until we have an order in place in the computer, which would allow us to do that.
And how do you get around that? Standing orders. Allowing you to use your brain to assess the situation, determine what's appropriate, what's not appropriate.
And,
Well,
you know,
I'm not
something,
allowed to bring, I'm an LPN, so
oh, yeah, you got,
I can't do anything without them saying it's okay.
and it used to just, floor
Yeah.
my nursing students when I tell them, you know, you can put on oxygen. You can administer before there's a written order. You can put, 2 liters, we're not throwing it on at 6 or something, but you can put it on because there should be a standing order for that. So, yeah, so how do you get standing orders written?
You have to work with the physicians. They
And-
have to learn to trust you, you have to learn to trust them.
And what do you need to do? You need to sit on nursing
Yep,
practice
nurse
council.
practice council.
So that's what I,
Take a
I
med
said.
exec,
Yep. So,
in the process of doing them right now.
Yeah, you should come work for
You
you.
need to
in
have that
Tacoma.
teamwork that you were talking about too.
mhm.
It's
Communication.
amazing still the differences in the hospitals and stuff like that, that there are still some hospitals where the doctor is here and the nurse is here,
Mhm.
and it's very uncomfortable.
I think what I have seen is that when we've got hospitalists that are right there on the floor, working with the nurses, they know their nurses, and they can have confidence in them, we're going to make more ground doing it that way. And also more advanced practice nurses that are assigned to the acute care setting and hold more of a leadership role in directing patient care. It's coming. It's coming. So, anything else? Well, thank you very much. I hope you found it helpful.